So good morning, good afternoon, or good evening, based on where you're joining us from, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization that provides stroke education to health professionals worldwide. It is with great pleasure that we are hosting this educational activity today on the topic of integrating palliative care into the ongoing treatment of people living with stroke. We have exceptional speakers sharing their knowledge on the topic, and this webinar is organized in collaboration with the Worldwide Hospice Palliative Care Alliance, and we'd like to personally thank their Executive Director, Dr. Stephen Connor, for helping us put together today's webinar and scientific program. Now, as per usual, before introducing today's chair, a quick look at some of our housekeeping rules. We welcome any questions that you might have throughout the webinar, but we kindly ask you to use the Q&A box for those in your Zoom control panel. So not the chat, but the Q&A box. The questions will be addressed at the end of the webinar during our Q&A discussion. You can, of course, use the chat box to say hi, let us know where you're joining us from, or leave any other comments. A reminder that this webinar is being recorded, and the recording link will be sent out to you via email shortly after the webinar, and it will also be uploaded on the World Stroke Academy site, so you can all access it. And lastly, we kindly invite you to fill in the evaluation survey at the end to share your feedback with us, of course, but also to claim your certificate of attendance. Now, without further ado, let me introduce our chair, Dr. Ivy Sebastian, Associate Professor at the Department of Neurology, Christian Medical College and Hospital in Ludhiana, India, Fellowship Stroke and CVD at the University of Calgary. She's a member of the Board of Directors and the Early Career Stroke Professionals Committee of the WSO and Global Consortium of Stroke Rehabilitation Core member. Dr. Sebastian, the floor is all yours.
Thank you, Laura. Hello, everyone, and welcome to today's session. First of all, I would like to thank World Stroke Academy for inviting me to moderate today's session, which will revolve around a very important topic, integrating palliative care into the comprehensive treatment of stroke patients. Stroke, as we all know, is a complex condition with multiple factors influencing survival and outcomes. And as clinicians, we often face tough and challenging discussions and decisions regarding palliation. However, despite its critical importance, this aspect of care is frequently overlooked in stroke management. Today, we are fortunate to have a panel of distinguished experts who will address various aspects of palliative care and stroke, ranging from symptom management to strategies for integrating palliative care into our clinical practices. So without further ado, I'm honored to introduce Dr. Stephen Connor to begin our session. He is the Executive Director of the Worldwide Hospice Palliative Care Alliance with 500 organizational members in 103 countries. He has worked in the hospice palliative care movement since 1975 as an executive, researcher, advocate, educator, and consultant, and is licensed as a clinical health psychologist with over 20 years of clinical experience. Dr. Connor has over 190 peer-reviewed publications and is the author and editor of 6 books on palliative care. We are very fortunate to have you, Dr. Connor, and he will provide us with an overview of the global need for stroke care. Dr. Connor, the floor is yours.
Thank you very much, Dr. Ivy. Let's put up the slides and get going. This is a really important topic that is an area of a need for palliative care that is not as well addressed as it should be. So we're really thrilled to have an opportunity to work with the World Stroke Academy and the World Stroke Organization to try to raise awareness about the need and importance of palliative care for people living with stroke. And the integration question, I think, is a critical one here because oftentimes palliative care is perceived as a kind of separate specialization that you go off somewhere to do. But actually, we want to see it. I mean, it really, in order to meet the needs of people living with stroke, it has to be integrated into the specializations that are involved in the care of people living with stroke. So, as mentioned, I'm the executive director for WHPCA. We're in official relations with WHO. I don't have any conflicts of interest to disclose. We don't accept any funding from anywhere that is in a conflict. My only interest is in improving access to palliative care for people who need it. For today, we're going to do, hopefully we'll be covering 4 objectives at the end of this session. I'll be describing the population of people needing palliative care that have experienced stroke. We'll talk about symptom management. We'll talk about understanding some of the physical, psychological, social, and practical needs of families, and particularly their caregivers who need a huge amount of support in caring for their loved ones after a stroke. And then hopefully we'll get some good questions, and we'll talk a little bit about how to integrate palliative care into your practice. So we know from the World Stroke Organization that that we have around 12 million people who experience stroke each year, and so that's the incidence. The mortality is about 6.5 million, and the prevalence is around 100 million people living with stroke. So it's a huge population of those who are ill. For those of you on the session who may not be that familiar with palliative care, this is the WHO definition, which is an approach that improves quality of life, really, both for adults and children who need palliative care, and their families. We always care for families along with patients. We never just care for the patients. Those who have life-threatening illness, and our main objective is to improve symptom management and to relieve suffering. These are people with serious health-related suffering. That's the marker for palliative care, not prognosis. So we try to identify early and correct and assess treatment. We do a lot of prevention as well as treatment. So because we know things that are going to happen, and the extent to which we can prevent them from resulting in suffering that is relievable, then we should do so, whether it's physical, psychological, social, or spiritual. This is a public health model on the right. That's a new description of how we build palliative care in each country. And the basement starts with actually, support from members of the community, from patients and their from families and those in communities around the person who's seriously ill. We have to have health policies. It has to be part of the healthcare system. We need evidence-based, more evidence-based research. But really, the pillars are education and training and access to medicine, essential medicines. And that's a significant problem worldwide, particularly for controlled substances. But we need those, and we can't really train people unless we have access to those medicines. But on the top in the roof, there's really integrated health services. So we're talking about integrating palliative care into the care. We published with WHO the Global Atlas of Palliative Care, which is in its 2nd edition, but we're working now on the 3rd edition. We, from that research and from the serious health-related suffering measurements that we've done, we find about 14% of adults need palliative care, a smaller percentage, about 0.5% of children. That it's around, at least this was back in 2000, the estimates were around 7.5 million adults and around 200,000 children needing palliative care. More recently, we've updated those estimates, and the numbers have increased to over 70 million people. But in looking at the need for stroke, we have close to 9 million people now who, out of that 100 million, that need some degree of palliative care. That includes people who are in the last year of life, around half, a little over half, and those who will be living longer. They're not in their last year of life. They're maybe a year, more than a year, sometimes 2 or 3 years or more before they die from their illness. Slightly more men than women, but really largely people living in low and middle income countries, over 85%, almost 86%. of people who need palliative care. These numbers and this data come from an article that we just published last month in Lancet Global Health, the evolution of serious health-related suffering. And these will be part of our new next atlas. So my takeaway message is, out of the 100 million people, almost 9 million will need some palliative care, some more than others, prior to or near the end of life. But definitely palliative care is not only about end-of-life care. It's really caring, again, for those with serious illness that have really serious suffering that they're experiencing. The vast majority living in low and middle income countries, and that palliative care really needs to be integrated into your practice out there. With that quick overview, I'm going to turn it over to our next speaker, Dr. Ivy. Please.
Thank you, Dr. Connor, for your excellent presentation, highlighting the global challenges and opportunities in stroke care. And thank you for bringing about this point that palliative care is not just always about end-of-life care, but encompasses a whole lot other points. At this point, I would like to remind our audience that Q&A is open. Please enter your questions into the Q&A box, and they will be addressed at the end of the session. Now for our next talk, I would like to introduce Professor Claire J. Creutzfeldt. After receiving her medical degree from the Ludwig Maximilian University in Germany, Professor Creutzfeldt completed her neurology residency, stroke fellowship, and postgraduate training in palliative care at the University of Washington in Seattle. Her research focuses on integrating palliative care into the emergent and ongoing care of patients with severe acute brain injury and their families, including people affected by stroke, traumatic brain injury, and cardiac arrest. Professor Creutzfeldt will speak on a very important topic, palliative and end-of-life care and stroke. Professor Creutzfeldt will look forward to hearing your insights.
Unmute. Hi, thanks everyone for being here and for being interested in this very important topic. And I think, as Dr. Connor already mentioned, it's this integration of palliative care into stroke care that's particularly important. And I'll tell you a little bit why I think that is. You heard the definition, sort of the WHO definition of palliative care. So palliative care is medical care that focuses on the care of those who are facing a serious life-threatening or life-altering illness. Palliative care, importantly, can be provided by the primary clinicians who are taking care of these patients, as well as, of course, our palliative care specialist consultants. Palliative care is characterized by a holistic assessment of what some people call palliative care needs. I think healthcare suffering is an important word, and Cicely Saunders used the word of total pain of an illness, and that's the word that we took over for this American Stroke Association scientific statement that we published earlier this year. This idea of total pain of stroke, and what this figure shows is those 4 big categories of sources of suffering, so emotional, physical, spiritual, existential, and psychosocial. It also shows that we are taking care of or caring for both the patient who is affected by the stroke themselves, as well as their care partner. They have distinct needs and they have shared needs. At the core of the palliative care needs for stroke, or even the total pain, we put communication and goals of care, and I will get to that later. I think that's a really important part, especially for stroke. As we think about integrating palliative care into any serious illness, I think it's really helpful to think about illness trajectories, and so how an illness sort of behaves from diagnosis to death. And so in this graph, you see function from low to high over time. And so that sort of traditional or classic palliative care diagnosis is cancer, where people tend to be diagnosed when they're still doing relatively well functionally. And have time to think about their goals, their treatment preferences, consider even end-of-life wishes, and then the decline is relatively rapid at the end, weeks to death. A second trajectory is the second most common actually for palliative care specialists, which is that of chronic illness with exacerbation, so congestive heart failure, COPD, or as neurologists, I think multiple sclerosis also falls into this. People tend to be diagnosed as they're still functioning quite well, and then have a very gradual decline with these exacerbations, some of which might cause a hospitalization, and all of which should probably be a trigger to readdress and consider goals of care, treatment preferences, values. The third trajectory is that of prolonged dwindling, typical ones being the neurodegenerative disorders, dementia, movement disorders, but of course aging is also one of them, and I think that illustrates that it's often hard to actually know when to talk about goals of care, treatment preferences, and values, and when to readdress them. The trajectory that we're talking about today is yet distinct, the one of stroke and other severe acute brain injuries. I will sometimes use the term severe acute brain injury, and with that I tend to mean the main ones being stroke, traumatic brain injury, and hypoxic ischemic encephalopathy after cardiac arrest. From a palliative care perspective, I think they share a lot of needs. Patients with stroke present at their worst, and right there is where we meet them. We tend to meet them when we have never met them before, and just here we go. And then right in this very early chaotic time, we often only get one opportunity to get a life-changing conversation right. So these loaded conversations at this very beginning cover immense ground: bad news, emotion, prognosis, treatment choices, and patient goals all play a part in coming up with the right plan for each individual patient. And so where this arrow is where a lot of people who die in the after severe stroke will actually die in the acute setting, and after a decision is made to withhold or withdraw life-sustaining treatment. Today, I actually want you to go home with that. I mean, if you go home with one message, I hope you go home with a lot of messages, but if there's one message that you go home with today, I want you to acknowledge that stroke is not an event. And it is actually a chronic illness for those survivors, and brings with it a multitude of challenges for patients, their care partners, and clinicians alike. For this statement, we actually thought of a trajectory as we think about stroke, which I think with different phases that I think might be helpful for us as clinicians to think about, what phase is my patient in at this moment. So again, starting with the diagnosis phase, this is a hyperacute phase, a chaotic phase, and what clinicians mostly will provide at this time is informational support. The diagnosis phase is, of course, immediately followed, or probably simultaneous with the acute treatment phase. So acute treatment after severe stroke typically necessitates intubation and mechanical ventilation, thrombectomy, brain surgery, and also artificial nutrition and hydration. Of course, conversations, as I said, also happen about withholding and withdrawing of life-sustaining treatment. The medical stabilization phase is when patients are medically stable. So we're no longer chasing the blood pressure, and maybe from an infectious perspective, they've stabilized, still at risk for infections. But I think the word stabilization is an important one in this case, because it is actually a time when we have conversations and need to make decisions about longer-term treatments, like percutaneous endoscopic gastrostomy for prolonged artificial nutrition. Need to think about overall goal concordant care. And because patients are medically stable but neurologically not stable, this can often come as a surprise for family members who are saying, but isn't there still so much happening with my loved one? And yes, there is, but medical stabilization means we should be able to focus more on rehab and disposition from the acute hospital and think about longer term treatments. The preparation phase is sort of this handoff idea from medicine to home to help prepare patients and families to leave the hospital or even a facility. The adjustment phase is then actually where the responsibility typically falls completely on the family care partners. And then the adaptation phase should really encompass this entire time. It's more of an emotional process, while I would say adjustment is more of a practical process. Adaptation should obviously be supported early, but is particularly important when the patient has neurologically stabilized. And then, of course, palliative care needs of patients and their care partners fluctuate over this illness course. And it's important for us as clinicians to reassess them based on events, symptoms, changes in function, and stage of illness. To do this, to have sort of ideas of reassessing, checklists can be helpful. So when we see the patient again, what is it we should think about? And this table is just one example of palliative care needs checklists, screening tools, triggers that can assist. Sorry, my slide thing isn't working very well. That can assist healthcare professionals. And so one of them that many of you, I'm sure, have heard is the surprise question, just this idea, would you be surprised if your patient died within the next year? If the answer to that is no, I wouldn't be surprised, then we probably need a conversation about goals of care, treatment preferences. Or I'll take another example from this table, you know, if there's a change in living situation, for example, the care partner can't take care of their loved one at home anymore, and they need to go to a different place. Another good time to reassess goals of care, but also symptom management and all of that. I talked a little bit about communication. We put it into, it's sort of the heart of the palliative care needs after stroke. And I strongly believe that communication is at the heart of every problem and also at the heart of every solution. And communication is also a skill that should be considered a skill like any surgical procedure. Atul Gawande wrote in his book Better about his experience as a surgical resident. And one of the things he said repeatedly, he talked about repeatedly, was this amazing privilege of being able to practice, to become an expert on a real person. And that privilege, of course, is possible only because we work as a team. And so I think that is exactly how we need to think about with communication as well. We're practicing on real people, but we're doing it as a team, and we're doing it together. And so one of my favorite personal examples was when I had a patient who was dying after severe stroke and had almost herniated, but not quite. And I think there was one reflex still left or something like that. And I was stumbling a little bit and trying to explain to the wife that he hadn't quite died. And the chaplain was sitting next to her and interrupted me and said to the wife, I think what Dr. Kreutzfeld is trying to say is that he's on his way. And that the wife understood that. And so I think communicating as a team and finding ways that match the person in front of us is important. Goal concordance is a primary aim of palliative care, and means that the care that we provide is aligned with the individual goals of care of that patient. And so our responsibility is to assess the patients and families' understanding and their perception of their current condition, as well as their values and preferences. We need to ask about their hopes and their fears for their future, including potential trade-offs. We need to provide tailored and honest information about the illness, about the prognosis, and about treatment options. And then we need to also consider a treatment recommendation that aligns with those. So the messages I want you to take away, at least today, are that stroke is not an event, but a chronic condition. That existing models of care should be adapted to promote the spectrum of goals, and these after stroke need to include curative, restorative, palliative, and end-of-life care. Stroke specialist training should include communication training, as well as multidimensional needs assessment and their tools. And palliative care specialists should be available for consultation when symptoms are refractory to first-line treatment, when care partners are experiencing severe distress or burnout, or when a goals of care or prognosis conversations requires more in-depth and training. So with that, I will pass on to the next speaker.
Thank you so much, Professor Krutzwil, for shedding light on the critical role of communication and setting goals of care, and the huge importance of communicating as a team. I'm sure there are going to be many questions from our audience on this, but moving on to our next topic. Our third speaker is Dr. Roop Kumar Gursahani from PD Hinduja Hospital and Research Center in Mumbai, India. Dr. Gursahani will discuss managing chronic diseases and symptom management from an LMIC perspective, a topic that is especially relevant given the unique challenges faced by low and middle income countries. Dr. Gursahani, please.
Thank you. Am I audible?
Yes, you.
Yes. So here is my screen. Right. So thank you, Dr. Conner, Claire, and everybody who's on this call. Pleasure to meet the rest of the panelists. I'm going to skip this slide because we've had a certain amount of discussion about how the big picture is shaping up, except just to point out that after the 1990s, it has been somewhat of a change in international health policy, pivoting away from child health and infections. We've already been told that lower and middle income countries where 80% of the burden of neurologic disorders and the associated disability. As part of my brief, I was tasked with looking up literature as well from the LMICs. Unfortunately, even with the help of the rabbit, I could only find these three. And the first is a descriptive study of 13 patients with severe stroke who died in the ICU in Congo. And I turned up this new term, therapeutic relentlessness. India has a qualitative study of doctors' perspective on PC needs, and mainland China has a much wider paper on PC needs and uses post-stroke. There are other papers from Southeast Asia and so on, but not LMICs. And then, as I looked up epidemiology, I realized that in India, there are parts of India where stroke is actually the leading cause of death. This is a rural, predominantly tribal area of India, and stroke is the biggest cause of death. Part of this is because various parts of India are transitioning through various stages of epidemiologic development. We thought we were in the age of pestilence and famine, but we have already crossed that into receding pandemics and into degenerative man-made diseases. And this really is changing as we watch. So it's quite interesting. India is changing and it is pretty diverse. What about palliative care for stroke? What about numbers? Well, we know that stroke does account for a substantial number of medical and neurologic admissions. And as we've already been told, it is bad news. 20% dead and 35% dependent. What about palliative care at home in rural Kerala, probably where palliative care is best managed in India? In one particular series, out of 104 patients that were enrolled a third were stroke, already double the number of those with cancer. Another study from rural Haryana looked at 1831 households and found stroke pretty substantial in these as well. Then we have the longitudinal aging study of India, and it again, I couldn't correlate exactly how many of these were stroke, but about 12% of them had PC needs, and in the stroke survivors, 64% of them needed palliative care. Now, one problem is that India doesn't have universal health care. That is part of the reason why our performance in the quality of death indices is still pretty low. This is now the third edition of this, and we are still pretty low down. But there are other things that there has been some improvement. One is that palliative care is becoming more and more available. One index of that is the removal of restrictions on the availability of morphine, and there we are getting better. But on other matters, especially of training, well, it has come up into our palliative care has come up into our general medical curriculum, but not a little patchily. We still don't have much public awareness of death matters, and patient autonomy still tends to be circumscribed by families. So healthcare in today's India is actually very diverse. And one way of looking at it is through the lens of the under 5 mortality rate. The landlocked state of Uttar Pradesh and the next one next to it really match Afghanistan and Burundi. And yet, at the end of the Indian peninsula, there are states whose numbers match those of fully developed countries. So you can understand providing palliative care in something as diverse as this is difficult, especially when we don't have universal health care. So one aim is obviously we do have a public system of healthcare, and one aim is to provide quality palliative care through that. May not be totally realistic. In the private system, which actually is fairly substantial, we are hoping to enlighten private hospital management and get insurance support. Not very successfully yet. The bulk of the load is carried by not-for-profits, and as I will talk a little further, by a concept called compassionate communities. So in the compassionate communities model, where it is a community who decides who needs palliative care, we are already seeing a shift away from cancer. So for instance, the first of these started in a place called Mallapuram in Kerala, and this paper was published some years ago. They analyzed 20 years of data. When they began, 90% of their work was cancer, and now just about 30% is. The bulk is dementia, and there's a fair amount of stroke, and stroke gets represented elsewhere as well. So what does palliative care in Kerala mean? It means volunteer support. These are trained volunteers, both who are involved in both mobilizing funds, efforts, offering psychosocial support. Dedicated palliative care nurses do follow-up home visits and supplement this volunteer support. The frequency of visit depends on the condition of the patient, and they actually empower family in basic care of bedridden patients, together with wound care, catheter care, nasogastric care, and so on. Basic physiotherapy is provided, and then there is supervision by doctors. And at least in Kerala, the local governments now provide a substantial bit of support from their own budgets, and you'll understand that. So some lessons from Kerala. One is that palliative care has to be framed as a social experience. Give up the idea that we as professionals have control. It is only then that individuals, families, and communities take ownership. And finally, dying, caring, caregiving, and grief become mainstreamed as life and living issues. You get better participation from the community with social responsibility. There's less dependence on professionals, less ignorance about all these issues, less fear and helplessness, and especially greater access, especially for the vulnerable. So the recipe actually starts off with sensitizing the community, orienting this to the healthcare system. Health roles and responsibilities tend to have to be defined between, say, the not-for-profit that runs this. Eventually, we are aiming at training the community as a whole. A pilot project is then followed by an audit cycle, and Kerala now has something like 2,000 of these units running around. Community programs are slow, but soon, once they gain critical mass, it becomes impossible for government and politicians to ignore them. And it's a little interesting to note that in Kerala, even local units of political parties sponsor these units. What happens in countries that have universal healthcare? As you can understand, it's not always easy to set these up there. But Kerala has shown that palliative care is everybody's business. And ideally, it should be community and government bodies working together. But Kerala has a secret sauce, which not many may be aware of. 2 millennia of trade with the world, decades of egalitarianism, and actually the first elected government, communist government in the world in the 1950s. Right. So let me move away from Kerala and talk about how neuropalliative care differs from oncopalliative care for those of you who are from the oncology side of this. Claire has already shown you these trajectories. In oncology, you have a defined trajectory, a prognosis. Once the patient crosses the inflection point, the prognosis is very set. And if there is transparency, a patient and family can retain control. Patients have voice till the end. And literally, the cancer makes all prognostic ethical and legal decisions, unlike us, where the erratic and prolonged trajectory often leads to recurrent admissions, and whether it is stroke or even dementia, the personhood is lost very early. So prognostic, ethical, and legal issues dominate. There's a quip that I heard from a colleague of mine in South India. As I said, in India, much of palliative care is provided by non-profits. She said that with cancer, the patient, my budget and my commitment all expire together. And you can see the trajectory that stroke actually goes through, literally bouncing around as they end up. So what are the barriers to neuropalliative care? The first and the major one are professional. About knowledge, perception, attitudes. From neurologists, very little exposure to palliative care during neurologic training. Then some are concerned about losing control. Others believe in their omnicompetence. From palliative care professionals, the biggest issue is diffidence. You can call it neurophobia. They avoid taking on neurology patients. Neurology and palliative care have historically had little interaction except through amyotrophic lateral sclerosis. And as I said earlier, it's also a question of resources. When palliative care is provided by charity or not-for-profit, it makes budgeting difficult. Even otherwise, when palliative care is provided top-down, it always ends up with cancer. And of course, you have community attitudes to death and dying in non-oncology settings. Once malignancy is on the table, everybody kind of understands which way it is going. So how do I look at this working as an individual, approaching a given patient? These are the domains of palliative care. My structure and process of care, where I practice in an LMIC, focuses first of all on training caregivers. We don't have volunteers, but for care at home. For physical symptoms, I focus on the systematic use of validated tools so that I can pick up the symptoms that need to be managed, regularly screen them for anxiety, depression, and behavioral and psychiatric symptoms, and monitor both caregivers, maybe even myself, who burn out. When you look at family structures, you focus on resilience and coping, help them do that. Sometimes we use something called tough love. For spiritual issues, I use this one-line screen, "Are you at peace?" which translates well into almost any language. And in India, you have this concept of seva, that is service, where it is blessed both to give and to receive. Culturally, you have to be sensitive to class and ethnicity and sexual identity, understanding when the chosen and the given family might be different. I have to be prepared, as Claire emphasized, to shift from evidence to preference-based medicine, preparing the caregiver for signposts of decline. And fortunately, in India, professional guidelines have now evolved to allow us to do the right thing and be protected for doing so. I'm not going to, if anybody is interested, this is available free. Remember that palliative care is the map, not the destination. And as the practitioner, you are the Sherpa, you know this route. It is your responsibility to handhold them through it. I'll end with these take-home messages. Stroke is a substantial component of palliative care needs at the population level in the LMICs. It's best provided as a component of universal healthcare or through community participation, ideally both, but that doesn't seem to happen. And as a practitioner, we have the responsibility of addressing all domains of care. Thank you. These references, some of those that I quoted will be here. And I'm happy to be contacted if anybody needs anything more. Thank you.
Thank you, Dr. Gursahani, for your very valuable and unique insights from an LMIC perspective. Finally, moving on to our fourth talk, I'm delighted to introduce our speaker, Dr. Rosa Lisbeth Quispe. Dr. Quispe holds a Global Health MPH from University of Washington and is a tenured professor and head of neurology course in the vascular department of neurology at the National Institute of Neurological Sciences, Peru. Her academic interests include building post-acute management in stroke under implementation sciences research, long-term outcomes of patients and their families after severe stroke, advancing neurological care in resource-limited settings, and medical education. She will present on stroke rehabilitation in Peru, country realities, highlighting practical approaches and barriers faced in the region. Dr. Quispe, over to you.
Good afternoon, everyone. Thank you for the opportunity. Today, I'm going to talk about the stroke support in Peru and our country realities. As we know, stroke represents the third cause of mortality in las Americas, showing an increasing trend in Peru, mostly in young adults. Also, it's important to state that most of our population are assisted by a public health insurance, which is intended to cover all expenses related to any health issues. However, patients and families face many challenges related to stroke care. Main identified gaps are insufficient caregiver training and lack of stroke support after the acute stage. It means a family member has to become a caregiver, having a limited or lack of training, limited access to rehabilitation support, lack of nursing homes, negative impact on family budgets, leading to caregivers' burden and poor patient quality of life. This data then shows that the household spend more than 40% of the family income to stroke care and treatment, becoming a catastrophic spending since the stroke diagnosis to the follow-up for our Peruvian families. This mental map shows the rehabilitation access in a public setting. When a patient goes home after the stroke, studies report that at least 50% of these patients do not receive any type of rehabilitation. The other half are assisted by a public health facility where administrative document requirements, the lack of early rehabilitation appointments, or limited capacity of the hospital delay the beginning of the public therapy, having a negative impact on functional recovery. And as an alternative, some patients with economic support have or look for private therapies to try to improve, meanwhile they are waiting for the public health assistance. There is a special situation for a patient who have a severe disability. If they have economic support, they also seek for private therapies, given the inconvenience for time, transportation, and cost from their houses to the hospital. However, given the limited budget, many of the patients do not complete the rehabilitation. All these barriers related to the rehabilitation access have a negative impact on patients' functional recovery and quality of life. That is not surprising that we have over 20% of stroke mortality after 1 year follow-up based on a previous study. What is the situation of palliative care in my country? A recent paper reports that less than 50% of the healthcare workers know about palliative care advance directive. Less than 10% of them have received a formal palliative care training. Also, palliative care tools are not applied, and there is a lack of knowledge on palliative care policies and guidance. Therefore, we are focused on improving the post-stroke care in our setting. For this purpose, we designed and implemented an educational training for caregivers through a pilot study under the implementation science framework and mixed method design. This training was focused on daily care assistance, and we found our intervention to be feasible and acceptable in our population. Main facilitator was the willingness to participate in the intervention from caregivers and stroke nursing staff. Main barriers were caregivers' burden and stressful family dynamics. Our next step is to develop a multi-component intervention with integrating palliative care components. In our setting, rehabilitation becomes a huge impact for catastrophic spending in Peruvian households. Also, we believe the palliative care recommendations, training, and guidance are a key factor to improve stroke survivors' quality of life. Finally, we need to integrate rehabilitation and palliative care for stroke survivors. In consequence, comprehensive post-stroke care interventions are needed. Thank you so much.
Thank you so much, Dr. Quispe, for sharing your experiences on stroke rehabilitation within the context of Peru. We now open the floor for questions, and I see that there are a few questions in the chat box. So one of the questions is, how do you communicate to a patient who can no longer speak besides talking with the family? Any tips? This is open to all the speakers. And an added question to that is, for palliative care at home, who should be trained to provide care at home?
We train the families, and that family is defined fairly largely as, you know, anyone with a close relationship with the patient. It's not necessarily people with blood relatives and things. Just to comment on the question about communication, speech therapists, you know, as Dr. Cressfeld said, are very valuable in working with stroke patients and not assuming that they can't communicate if their speech is impaired. There are, you know, letter boards and lots of techniques for helping the patient communicate their thoughts and feelings.
And just to add on, is this, that's, I think, what is so unique about palliative care after stroke is that it needs to have all these, it needs to also integrate rehab therapies into it. And unfortunately, and I think, Roop, you could talk about that also in your country. In our country, it tends to be either or, and that, of course, needs to be changed.
Yeah.
Right. Am I audible?
Dr.
Yeah.
Lopez.
Yeah. So
Yeah, Dr.
so one of the questions that actually came up in the chat, and I'll go on to this, is how do you start communicating? And I actually take on from a graphic that Claire has published about how in the initial stages of a severe stroke, the first priority is establishing trust. And you do that at least by being realistic. And also, I find a technique that is pretty useful is negotiating a time-limited trial of maximal therapy. At the end of about 3 to 5 days is when you can start looking at prognosis. I'm talking of severe strokes, obviously. And then you can start figuring out in your own mind whether this is a patient that would move towards rehab or to foregoing life support. It takes the family some time to get to that point. For major strokes, that's the way. But for smaller strokes, one thing that we do not often address is the fact that these people now begin to live with uncertainty. a Damocles sword hanging over their heads. And in addition to rehab, I think reassurance is also our responsibility. Rehab, of course, is very important.
There was a question about the people who need palliative care, and it was touched on by Dr. Roop's presentation, that in fact, based on the research we've done with Lancet Commission, only about 30% of the need for palliative care is for oncology. And people often think, oh, palliative care is just for cancer patients. But in fact, as Dr. Roop said, it's clearly majority is non-cancer that need palliative care. Though the needs differ depending on the type of illness and, as we've said, the trajectory.
Yeah, there was another question regarding the stroke trajectory, stating that I'm surprised that adjustment and adaptation phase is a flat line. One of the biggest myths in stroke recovery has been the concept of plateau. And although Dr. Roop has answered it, but I think this would be a good question to have a discussion amongst the panelists.
Yeah, I think that's a really good point. We tend to think of stabilization, neurological stabilization, and so that's what that flat line tends to say. There's not a ton of research looking at people for many years. Patients will tell us over and over that it's not true, that they are still changing and still recovering. And the research mostly comes from modified Rankin scales. So someone who after about a year is unable to walk will probably not walk well. So that's what stabilization means. It doesn't mean that they're not going to gain more words, somehow find a different way to communicate over time. So you could give it a more fluctuating line. I do think that uncertainty of recovery becomes much, much less uncertain over time. And I do think that's important for patients and families to know, because it's very hard to adapt when you live still with uncertainty. And so if you think that big milestones are still about to happen, it's going to be much harder to try and adapt to what you have right now.
Yeah. I have a question which perhaps both Claire and Roop could answer. High-income countries, we tend to have advanced directives, and goals of care are kind of previously ordained amongst, and there's good public awareness about it. But there are a lot of communication challenges surrounding goals of care and advanced directives, especially in low-middle-income countries like India. Where these kind of frameworks are not commonly in place. And also, the addition of cultural beliefs and practices can further kind of influence the management of palliative care delivery in LMICs. Question to both of you, can you provide examples of how cultural considerations can be integrated into patient care, and how these kind of discussions with the family can be initiated, and when to take up these decisions and discussions while seeing patients with severe stroke?
You first, Claire.
There were a lot of questions in there. When I hear the word cultural considerations, the first thing that I think of is that all care that we provide is individualized. And so when I'm facing someone, especially when they are from a culture that I'm unfamiliar with, then I should ask them about what is most important to their culture. So I think that's my first answer to this.
Right. Maybe Dr. Gursahani, what I meant is probably you're more aware, we
Advanced
don't
care planning.
have the concept of goals of care in India. We don't have advanced directives when it comes to, it's a completely unfamiliar concept, and it could even be considered a little, challenging to kind of broach these conversations with families. How do you go about that when we don't have these frameworks in our settings?
So goals of care, actually, that's a whole lecture, but we whatever we do, whatever encounters we have, longevity, comfort, and function, these are the three goals that we always have, whether you're treating a respiratory tract infection or end of life. And towards the end of life, you actually have to choose between the three of them. You can't always have all three. I'm not sure if I'm clear on that, but that's something that families need to understand. Now, about advanced care planning, typically we follow a hierarchy. The hierarchy, the first is the patient's own express wish through a written document, and India is now, well, advanced directives are not only just legally valid, we are supposed to be enforcing them. I'm part of the group that's kind of working on them, but yeah, we still have a long way to go. Once that is not there, and one way of checking that out when you are interacting with the family is ask them, have there been instances of somebody who died in an ICU, and did your loved one say at that time, that's not what I want? That's a advanced directive. If you don't have anything of the kind, the next is you use substituted judgment. So ideally, the surrogate, we have to have a surrogate hierarchy. You follow that, of course, whatever is laid down in your own jurisdiction. In India, we do have one from the AIMS guidelines. And the third is best interest decision making. That best interest decision making is a little tricky because it is actually taking into account the wider ecosystem of the patient. Is this family going to be able to take care of this patient? What are their circumstances like? How will you support them? So if you have this framework to figure out, you can get a long way along this. Sorry, rather long answer.
Yeah. We're running a bit short on time, and I noticed an interesting question in the Q&A or in the chat about the role of rehabilitation in palliative care. And people often make a false assumption that rehabilitation is separate from palliative care. It's actually part of palliative care. It overlaps actually quite nicely, as Dr. Rosa has said. And it's part of quality of life to help people, function at their maximum, level of ability, even when they're in a situation where they have a shortened life expectancy. Of course, when someone's actively dying, we're not going to be doing rehabilitation very much. But I don't know if others have comment on this.
Yeah, I do actually have a comment, because that's the whole problem with stroke, is that the active dying phase is an extremely short one after stroke. But what people do often think about is hospice, which tends for them to mean I want to really focus on comfort. I don't want to be re-hospitalized again. If I get pretty sick, then I'd prefer to die rather than having to go through all of these things. That could be hospice, but then, at least in my country, in the United States, once you're on hospice, you don't get any rehab therapy. And I think that should be a big part of our advocacy, to explain how, especially when you have hemiparesis or even hemiplegia, you do need rehab therapies, or aphasia, of course, that has been mentioned a lot in the chat today. A very unique challenge to stroke is you need rehab therapists to improve your quality of life, even if it may not, get you back to independence or anything like that.
Yeah.
Actually, having worked in hospice in the U.S. for decades, we do have physical therapists. We usually nurses, oftentimes, for physical therapy in the home health aides, but it isn't completely.
I think great argument to get families and care partners trained, exactly like Dr. Ecos Liz is doing in Peru.
Right.
Laura, how are we doing for time? If we have a few minutes, I have one last question for Dr. Corner. I would love to know a little bit more about WHPCA and what role can international organizations like yours play in, advocating for integration of palliative care into our clinical practices.
Well, as Dr. Roop said, I mean, one of our big objectives for palliative care globally is to be able to make sure every country has palliative care in their universal health coverage packages. But as it was also discussed, the basement of the house is community empowerment and involvement of families and communities, as has been, brilliantly shown in Kerala and other parts of India, and other countries now are also doing that because of limited resources, volunteers, having family members involving. It's everybody's business, as was said. But at the same time, governments have responsibilities, and so we're advocating for palliative care at the World Health Organization and the World Health Assembly and the Commission on Narcotic Drugs and other places, because we're in official relations. We get to have a voice, though it's very limited compared to the member states. It's better if the countries speak up and ask for palliative care than for advocates for us to speak up. And it's also important for people with lived experience to talk about what palliative care means to them. So we are trying to enable all of that sort of voice to be heard at the global policy level, which is why we were formed by the national organizations to lift the voice of palliative care up in the global policy arena. But it still has to happen at the country level and at the local level. All care is local. But if you're interested in being a member, and it's not we don't actually charge for membership. You just go on our website, www.thewhpca.org, and membership, and organizations can join. We don't have individual members, but along with the rest of the global palliative care community, the International Association for Hospice and Palliative Care, and the Children's Network, we're the advocates, and we're thrilled to have this World Stroke Academy pay attention to this somewhat neglected topic. And I think it's right that there is, it's not just the palliative care community needs to pay more attention to the needs of people with stroke, as well as the neurology world. So thank you, everybody.
Very interesting. Thank you, Dr. Conner. I think we had a lot of questions, but Dr. Roop has assisted by answering almost all of them in the chat box itself. Thank you so much. Laura, I think we are right on time. So to conclude, I would just like to thank all the speakers, express my heartfelt gratitude for their insightful presentations and contributions today. I think this was a very interesting topic to touch upon. Like Dr. Conner mentioned, something which is sometimes or quite often neglected in our practices for stroke care. But it is an essential endeavor to integrate palliative care into our stroke management to significantly improve patient outcomes and quality of life. Thank you, everyone, for joining. Yes, Dr.
Just one thing, if you want to learn more about palliative care and get training, there are basic training programs in palliative care. It's usually 3 to 5 days of training, but to get basically trained in palliative care is the first step, and it's really important to have that skill set and bring it into your practice. Thank you.
I can have just one word. The INPCS has lots of stuff that is not just free, but there are links that you can pick up to learn about neuropalliative care. I run the International Neuropalliative Care Certificate course, and it's not too expensive. Just go on the INPCS website, you'll get lots of stuff.
And join the INPCS.
Yeah.
Yes.
As long with
share all the links.
Yeah.
Right.
Very good.
So we have a lot of thanks and appreciation from all the members in the audience. Thank you so much. Laura, would you like to close?
Thank you, Ivy. Indeed, wonderful discussions, great presentations and questions. We thank everyone as per usual for their warm participation. Thank you to our chair, to our speakers for contributing. As mentioned, the recorded version of this webinar will be shared with everyone and will also be uploaded on the World Stroke Academy site. I will make sure to include all links and resources there as well. In the meanwhile, you can follow us on X and on LinkedIn for upcoming educational activities. And just a reminder to fill in the evaluation survey. Your feedback is very important to us, and you can also claim your certificate of attendance there as well. So until the next webinar, take care, everyone. And thank you once again for joining.
Thank you.
Bye,
Bye.
everyone.
Thank you so much. Bye.
Bye.
Well done, everyone. Timing was great.
Yeah.